Mic is okay, no? It's working. Hello. Hello, hello. टाइम का आदित्य बता देना कि कब स्टॉप करना है सो दैट A very good morning to all of you. And today we are having an excellent discussion for which we have three different, I should say, three different eminent faculties with me. First, I would like to introduce R.K. Mani sir. He is a director, clinical services and critical care, Yashoda Hospital, Kausambi, Ghaziabad. And sir is a chairman in expert committee for end of life care. Position statement given by sir in ISCCM and IAPC. Sir has led the technical resources group for the Ministry of Health and Family Welfare that forms the guidelines for withdrawal of life support in Indian ICUs and hospitals. After R.K. Mani sir, we have Dr. Mohan Maharaj sir, who is the Director of Critical Care and Pain Management, Medicover Hospital, Visakhapatnam. Sir is also Director of Morton Services and he is a DRNB IDCCM teacher as well. Along with us, we are having Dr. Ramakrishnan sir. Sir is a Director of Critical Care Medicine, Apollo Chennai, and he is also served as a past Vice Chancellor for Indian College of Critical Care Medicine. So my first question is for R.K. Mani sir. Sir, can you tell us that what are the key elements that should be included in an advanced directive to ensure it reflects a patient wishes accurately?
The key elements are that the patient should state that I am in full possession of my faculties and I am under no pressure or coercion to execute my advance will. And then it should state what are the preferences and values that guide medical decisions to be taken when he is facing terminal illness and not in possession of his faculties, his or her faculty. So these are the elements, and then there's another element which is included in the living will is to appoint a healthcare proxy to work with the caregiving team to implement the values and wishes that has been declared in the document. So he or she can declare which intervention, life support intervention, is to be not to be applied towards the end of life.
Okay. So my next question is for Mohan Maharaj sir, and we will discuss few important aspects of subarachnoid hemorrhage and what are the recent changes or recent guidelines that is in place. So leading to that, my first question is, sir, could you tell us the recent studies that have significantly changed the approach in managing subarachnoid hemorrhage in terms of early diagnosis and or treatment?
Thank you, Dr. Neeraj. As subarachnoid hemorrhage, particularly, mostly it's aneurysmal bleed is almost 85%. Only 15% comes to other aspects of the bleed. When it comes to that, as you said, particularly of recent or practice changing papers, I can tell you two papers of whether you call it as a early clipping or early coiling. So that comes from the what happens is ISAT study, and when you have three varieties of papers are there from which has been long standing for 2,143 patients have been included into that with multiple centers, which has been shown clearly that the coiling is more beneficial because previously the coiling was not developed. Once it is developed, they have taken over. They have studied even post hoc analysis and including 18 years of follow-up, still found out retreatment or rebleed. These are going to be little high when the complete coiling is not done. It's like 1.9% or 2.9%, which comes out 90% of coiling closure. But when it comes to the clipping, need to understand that here in SAH, including after the SAH, even though if you do the treatment of coiling on this one, the chances of 70% of the patients goes into vasospasm in that 40%. So finally, what we are looking at is 40% mortality is already there before they reach the hospital, and only the 40% we are going to work on it, which is going to be 58% of improvement if you do a practical protocolized treatment like giving nimodipine. And also you need to understand presently there is a 2023 guidelines which supposed to be done with Issuer trial and Brad trial of which is 10 years successful completion of this. And they have been said always you have to go through there are two positive studies and two negative studies. The positive studies is according to the ISAT and lumbar drainage where you can do, and in spite of high suspicion of the patients, you go with the lumbar drain to confirm it. Maybe you may not identify in the scan. As intensivist, we go for TCD regularly, looking at the velocity. But here, the most of the things as a pathophysiology, you're going to work on it and study. They have studied magnesium, they have studied statins, they have studied other drugs also, but only Milanon is working now. But magnesium doesn't show any outcome mortality benefit, even though mechanism has actually been proven. So these are the two negative trials of statin, and that is a STAS trial, including the HIHAS trial. So these are the trials which has been thinking about what sedation to be given and what is early. The best way is to do within 12 hours and maximum within 24 hours. And thinking about early identification of vasospasm and prevention. This is what 5 things. Please note, you need to send the patient to the neuro critical care center for a better outcomes. Thank you.
Thank you, sir. Now, I will ask one more question from Ramakrishnan, sir, because we are asking questions related to artificial intelligence and how it is going to enhance the patient risk stratification. So my first question to you, sir, that how these AI is going to improve and enhance the accuracy of patient risk stratification in healthcare.
Thank you. Artificial intelligence is really becoming a buzzword now in everything, not just healthcare, but in everything that we do. And like it or not, it is going to have significant impact on healthcare, and we better learn to adapt, honestly. I would say that, if you look at history, we have moved from a generation ahead of us that was totally relying on clinical judgment. And then maybe our generation had clinical judgment plus a lot of investigations. Additionally, we could benefit from those. Now, I think artificial intelligence is honestly trying to augment this human intelligence by, like getting all this information together in a way where you can risk stratify ahead of time, predict what is going to happen to the patient so that you could provide the right care at the right time. Like you can really try to understand when this patient is likely to deteriorate from the time to prediction to the time that the clinical deterioration actually happens is significant. And therefore, we can use risk prediction models using artificial intelligence to help the clinician's judgment. I'm emphasizing on the word because these AI models are not going to replace clinicians, but they are going to augment the the clinician's ability to risk stratify ahead of time, predict, and treat early.
Thank you, sir. Till now, our audience must have understand that we are having our discussion first related to advanced directives, second, some points related to subarachnoid hemorrhage, and third, what is the role of artificial intelligence in patient risk stratification. So just continuing to that, my second question to R.K. Mani sir is, sir, can you tell us that how these advanced directive drafting happens?
You see, there are model sample forms which may be available on Pallium India site or Vidhi Center for Legal Policy or Indian Association of Palliative Care websites. So the drafting is done by the one who executes it, as I said, including those elements. And then it should be signed by two independent witnesses in the presence of a notary or a gazetted officer. This is sufficient. You do not have to involve the district jurisdictional magistrate of the first class, as was the opinion in 2018 judgment, but this has got simplified in the 2023 judgment. Now, once this is executed, you may give a copy of this to the appointed proxy, the named proxies in the document, your family physician, rest of the family, family members who may represent you, and you may also save it with the custodian named by the state government authorities, custodian either in the municipal corporation or municipality or local panchayat.
Okay. Okay. Thank you, sir. My next question is to Mohan Maharaj, sir. Sir, could you able to tell us that what are the advances that has happened in imaging technologies for early detection and risk assessment of SAH?
More than I can say that as intensivist, we are very well versed with the POCUS, and now we have been going to identify the TCD, and before that we go for the what transcranial diopter gives us a velocity difference. But when it comes to the advancement of investigations, as previously I mentioned, as Dr. Ramakrishnan sir were talking about artificial intelligence, there is a machine learning which is coming with the cortical encephalography, which can be given as a mortality and understanding of precision treatment with the patient management and looking at the what is the mortality of that patient. Coming to the cases, as I told that in the CT scan it's not going to be visible. Then if you have a high suspicion of that you have a throbbing headache and it's like worst headache of life and list of things of focal deficits, anything is there, you go for, if the CT scan is not there, lumbar drain. At the same time, you please understand here, not only the CT scan, the CT angio, which gives the vessel vascularity, and digital subtraction angio, which is going to give much more clearer picture that what is going to be decision. Because if you see the studies, either whenever you are looking at the coiling or clipping, a surgical clipping, both can be done, but depends on the circle of Willis, whether it's anteriorly or posteriorly. Particularly posteriorly coiling is better and anteriorly clipping is better, was a study, and where they continuously doing it presently with the advancement technology, what is going to be done. And now with the DSA, we are going for a flow diverter also for the major aneurysmal areas of this one, where we have actually 3 intervention radiologists. We do lot of cases of those. So here the advance of this is, you have a very good advancement of radiological techniques to get the patient's identification and proper management of the patient. Thank you.
Thank you, sir. Also, my questions continue with Ramakrishnan sir. Sir, I will want to ask that how these AI-based algorithm can be integrated into the current clinical practice without disrupting the patient care, or you can say that without disrupting the healthcare team.
So before I answer that, I do want to kind of outline 2 terms that are often used in artificial intelligence. One is machine learning, about which Mohan Maharaj was also mentioning. So what happens in machine learning is whatever data is existing, and I'm talking about numbers and data are existing, these can be learned by the computer systems to come up with algorithms, and that can be implemented in the risk stratification and clinical workflow. The second thing is what we call natural language processing. This involves more documents, and I'm talking about our history and physical that as doctors we have, documented, or anything. Those are, like language documents that can also be incorporated. Now, why I wanted to bring both of this is you were saying that how can we integrate this into clinical workflows? To integrate it into clinical workflows, we obviously need to be a lot more electronically moving our systems, and for that we need electronic medical records, which unfortunately do not exist even in several of the large, corporate and private hospital systems in India, which is a huge factor that impacts and delays our implementation of artificial intelligence. However, there are some specific ones that are available. For example, like imaging seems to be available in data format that can be incorporated. Lab systems are available that can be incorporated without affecting our workflow. There are opportunities for us to directly capture the data from our monitors, from our mechanical ventilator, from our pumps, and all of those, which again we have not done enough. But if those are done, it will not affect our workflow, and those can be automatically directly captured and provide us options for risk stratification and improving more patient targeted therapies. Along those lines, when I talk about natural language processing, the issue is that we still on paper documents for right from nursing documentation to doctors documentation. All of those are on paper. There are so many advanced systems that are coming with voice recognition softwares, which can simplify and in fact it can reduce our time for documentation, but still we have not adapted widely on those. So if we start using these more electronic medical records, more of all these data being integrated directly from the system where it is entered, I think we can incorporate artificial intelligence without affecting our daily workflow. In fact, our workflow would be much easier and less time consuming.
Yes, thank you. Sir, my question to R.K. Mani, sir, as we discussed regarding the process of drafting, right, sir? So now my question is that how do these healthcare providers have any role in assisting the patients with drafting for these advanced directives?
Yeah, it's very important to understand that patient who is drafting an advance will may only be partially or not fully informed about the situations anticipated. Okay, the anticipated situation of terminal illness may not be visualized in an informed way. And this is what the healthcare workers can assist in. Assist the patient early enough in engaging the patient in conversations around death and dying and of values and preferences that the patient may be having. Because to engage in this conversation takes a bit of time. It takes it evolves over a period of time. This should be done early enough in the course of the illness. Say a cancer process or a chronic illness, advancing illness. So early enough that if they open up the conversations, and the patient can also engage with other persons like facilitators or counselors, or psychologists who may help the patient to confront and accept the anticipated circumstances and death. In an informed way, if you execute an AMD, then it will be done with the least amount of pressure, okay, either external or psychological pressure. It will be done in a fully aware manner as to what to expect and how to engage with those circumstances in a way it is self-determined.
Okay. Sir, my next question is to Mohan Maharaj, sir. As we have discussed the advances that is required for that management of subarachnoid hemorrhage, we know that, sir, that there is a term that delayed cerebral ischemia, right, which happens after subarachnoid hemorrhage. So my question is, sir, that is there any different management that is going to play for the management of DCI following SAH?
As the complication of SAH, even post therapy is a mechanism of vasospasm, because of where there is a blood is coming out and that's becoming a hepatoglobin, which is going to be broken and going to stimulate the endothelium, and endothelium damage at the same time is going to complex have interleukins released, that is going to cause this apoptosis, and which is going to cause this. In spite of this, as I was telling in the first question itself, that 80% of the people in the ICU post SH will get vasospasm, but how many of them going to DCND or DCI is going to be only 38 to 40%. In that, the early identification is the most important factor. As I told you, regular interval doing the TCD and looking at the velocity, understanding first. But as a clinical picture, just to say that vasoconstriction is different from the vasospasm. Spasm is sudden, which can occur between third day to 14th day. That is the reason all the trials have been done and given like nimodipine for 21 days, where they can expect it to be have a better outcome every 4th hourly, 60 mg. At the same time here, different studies has been done. STAS trial, MASH trial, that's for magnesium, and also for you are going to the MASH trial 1 and 2, and including the endothelium test, Clausus centon, which actually antagonist for endothelin, because the mechanism of pathophysiology we want to stop. But none of these studies have shown a mortality benefit or outcome. But it has been shown the difference in the vasospasm, reduction of the vasospasm, not reflected to the mortality. But if you see the Montreal hospital protocol where they made it, the mildenon intravascular, because you have the balloon angiography done and they tried it, and at the same time even post procedure once that is been done also, the difference between the coiling and the clipping, post coiling retreatment and rebleeding was little more compared to the clipping. But after advancement of the technology and the equipment recently, it has been very well confirmed that the coiling is better. To prevent the vasospasm, definitely mildenon is beneficial and useful. So this is what regarding the DCI. Thank you.
Thank you, sir. So continuing my question with Ramakrishnan sir. Sir, we have already discussed that AI-driven algorithm for that, how it's going to get integrated. Just continuing with that, my next question is that what are the various technical challenges that that will be exist in implementing this AI?
Yeah, I kind of alluded to this in my earlier response as well. The main thing is having technology available in the hospital systems is the main challenge, I would say, because while paper data may be widely available, there is a lot of variability in that, and like integrating that to develop artificial intelligence systems is going to be a lot more difficult. I've always been amazed at how India has created a lot of technology for the world, but our adaptation of technology has been much slower than most other countries. In fact, when we use systems in other countries, when I have worked there, I think a lot of them were developed by, programmers and software developers here. So I really think that our challenge is in incorporating more technology, and that's partly because we are a very, very price sensitive market. And I think in general, people think technology is going to add costs. However, they forget the fact that, like it is going to simplify the processes. It is going to have, I mean, our resource allocation can significantly change. We can use systems to identify who are the people who are going to require more focused care. Like for example, even assigning nurses, which patients would require one nurse, one-to-one nursing versus one-to-two nursing. Several of those resource allocations can be done using incorporated technology, which I think is our biggest challenge. We really need to start adapting it. There's data beginning to come out on several specific aspects of right from emergency care to critical care, where like we can augment the processes, augment the workflows. However, as with anything else, it's like garbage in and garbage out. So you really, unless you have enough appropriate data, I think the output of these artificial intelligence systems is also going to be unacceptable.
Okay, thank you, sir. Sir, my next question to R.K. Mani sir regarding means I was thinking that whether these healthcare professionals, if we made advanced directives, right? So how this is going to be applied for any medical emergencies or end of life care?
Yes. So you see, as I mentioned, the health caregivers can prepare the patient with this advanced care planning, conversations around death and dying. So what it happens is it reduces the unnecessary resource utilization. Patient may decide, patient or family may decide not to come to the hospital towards the end. Even if they do come, they are mentally prepared for a conversation around not intervening with life support technologies. So this is the advantage of a full-fledged counseling process around an advanced medical directive execution, because the execution is done in a well-informed manner. If there is available AMD, that will help the healthcare workers again to zero down on the correct decision very quickly. So it can be done even at the emergency level. If the patient is brought in in an unstable condition, the physicians may decide not to intervene, respecting the patient's choice. That has been documented in the AMD, and also having had the opportunity to discuss it around. And the similar thing in the critical care setting, if it's not in the emergency, then the critical care setting, this can be addressed, and communication between the healthcare workers and the family can be around the patient's choice and respecting them.
Yes, thank you. My next question is to Mohan Maharaj, sir. Sir, we have discussed the management strategies for DCI. Now, I would like to ask, sir, can you tell us something about the role of that clipping versus surgical clipping, or you can say that AV coiling versus surgical clipping in management of aneurysmal bleed. Sir, is there any practice changing papers that is there?
I think mentioned already regarding the ISTAT and ISUA and BRAD study, and recently whatever the advancement of this. Just before this, as is going to be video, I just want to keep 3 points to be remembered by the people. Previously thought about triple H therapy, please forget about it. And 3 things not to do is that do not give anti-epileptics beforehand, and at the same time maintain euvolemia, don't give hypervolemia. And the third point I wanted to say that fibrinolytic therapy whenever you are giving, and within 72 hours. These are things to be remembered. What should not be done is more important here. And when it comes to the what should be done of this one, as we told in the Millinon and Montreal hospital protocol system wise going to the ABCD here, and prevention of the vasospasm is going to be mainstay. But coming to the sedation protocol, when you want to give the patient on management of, you have a grading, Henton has as a classification, or particularly what we are looking at the outcome is that you have got modified Rankin scale. So which is actually you want to maintain, because most of these people go for the, out of this 15 to 20% of the people go for the rehabilitation. In that we have to give, better to give ketamine, which actually works for cortical spreading decortication, depolarization, which is going to be useful, and dexmedetomidine being used. So whenever you're looking at this, the continuous monitoring, continuous assessment, which makes us to understand, looking at this, all these complications by the critical care specialist improves the patient. Coming to the study of this one, definitely coiling is better than clipping. Thanks.
Thank you, sir, for clearing this important aspect. Now, my next question to Ramakrishnan, sir, as we have discussed the technical challenges, right, with AI implementation. Sir, can you tell us few things about these AI tools, whether they are really helpful in patient data privacy, or whether any ethical standards are there? Could you able to tell us something about that?
Absolutely. I mean, that's one thing that we are always concerned about. Any data, and the privacy plays a huge factor. I think, first of all, we as clinicians, as doctors, should understand what AI is doing, how it is actually capturing the data. And we also need to understand, like the ethical aspects of how those were captured. Obviously, like it is what we are providing, the information is what we are providing. But if there have been like unknown hacking methods, I mean, there's also ethical hacking. That's not what I'm talking about. But if there are other ways in which we are losing the information, then that's a big problem. Now, there are countries where there are large data sets available. For example, the telecritical care data is available huge numbers in the US, the large volume. That has been used to develop several algorithms. So as long as we are clear that the data was appropriately captured, ethically captured, patient security has been maintained, patient privacy has been maintained, that is good. And like, while we are great with having some international data like that has developed algorithms, it's always important to develop our own algorithms, because there are some, if not huge, there are definitely some subtle differences that we may see in our own practices compared to the Western world. That apart, I think it is also important for us to be transparent and telling the patient on what has been directly driven by us, and some of this may have had an influence from the artificial intelligence. And clearly, we need to avoid biases based purely on what the artificial intelligence is telling us. So, which is why I even kind of reinforced earlier that artificial intelligence is here to augment our work and augment our clinical workflow, improve risk stratification, all of those, but certainly not to replace the clinician. So, as long as we are convinced and we are able to tell the patients and the families on how this has been done, I really think it can be useful. And there are several applications that are already coming specific for critical care practice. For example, sepsis. There are lots and lots of data in sepsis that have helped us to identify what, if done at the right time, quickly, would definitely improve the outcomes, whether it is reducing morbidity, reducing mortality, and all of those. Now, I can tell you, as somebody who does telecritical care internationally, there are systems that alert us. The moment I log into a patient's data, it alerts me saying that, based on the algorithm, this patient appears to have sepsis. So this is a sepsis alert that we get, saying that we have to complete saying, do we clinically think that the patient has sepsis? And only then move forward in right from giving fluids. Now, having said that, when it comes to the, like decision making, sometimes we consciously try to override that. And it happened to me recently in real life, where there was a patient where on audit, I was asked, this patient had a sepsis alert triggered, but you did not give fluids for 30 ml per kilogram. Now, that was an obvious override that I had done clinically, because the patient had history of heart failure, had a high BNP, like clinically was sounding congested. So I think it's important for us to understand that these systems are there. Clearly, all this machine learning, more data that is in, it would definitely help. None of it includes specific patient data, so there is definitely patient privacy included in that. But while delivering care, it certainly makes a difference.
Okay, thank you, sir. As we are running short of time, so I will just ask last question from RK Mani, sir. Sir, could you enumerate some of the ethical considerations that is involved in respecting or overriding an advance directive, especially if when a patient condition is ambiguous or if a patient condition is not very clear?
So the ethical pillars involve not only autonomy, it also involves the the care, healthcare care duties, caregiving duty, which is beneficence and non-maleficence. That is, you have to balance the benefit versus harms, or whatever intervention is being accepted or refused. And similarly, in the larger perspective, distributive justice. Okay, whether it is this resource utilization is justifiable in the larger interest of the society or not. So that way, all the four principles have to be employed with equal importance. It's autonomy is only one element, and of course, what drives declaration of an advanced medical directive is to ensure that the autonomy is not lost when you have lost capacity. That continues through an instrument. But that doesn't mean that you can apply the declaration without crunching it through beneficence and non-maleficence and the social justice. So you have to balance the four elements, ethical pillars, before you arrive at a decision and implement.
Thank you, sir. Sir, only my also last questions to Mohan sir. That do we have any recent advancement or guidelines, sir, for post-stroke rehabilitation in SH patients? Sir, just enumerate in 2 or 3 words because we are running short of time.
Yeah,
Thank you.
just to close it fast because of without rehabilitation, the quality of life Euro qual score is there. But looking at one important thing is that hyperbaric oxygen has become very important aspect of the patients where it can stimulate and it will be beneficial. Second thing is you have a neuromodulation and you have a direct transcranial Doppler stimulation, brain stimulation is there. At the same time, you have a trigeminal nerve stimulation is there. These are things which are actually useful in rehabilitation, which actually studied 11,000 patients for stroke patients, but SAH there is no proper way of exactly not done. But definitely these are going to be useful. It to be taken considered at the time of the bleed itself to be considered about rehabilitation is one of the important aspect. Behavioral, physical, and all the aspects has to be looked into the patient's condition when you look for the goals of the rehabilitation.
Thank you. Thank you so much, sir. Similarly, last question to Ramakrishnan sir also, as sir has talked to two important things about artificial intelligence. So my last question is, sir, do these artificial intelligence have potential long-term benefits to enhance the clinical workflow? Only 3 or 4 points, sir, if you want to highlight.
Yeah, I mean, as I said, artificial intelligence is here to stay, and we better learn to incorporate it in our clinical practice. And in the long run, it helps in several things, not just like a risk stratification, clinical workflow to improve the patient outcomes. But more importantly, there are methodologies where we can follow these patients long term. Post ICU care is becoming a significant thing. Preventing ICU readmissions is another important aspect. So, and rehabilitation post ICU care as well can all be done. And so there's a lot of long-term applications that we can use with the existing data and develop more algorithms, again, with the help of the clinicians.
Thank you all our expert panelists for answering so well, and I think we have asked few important questions related to this topic, and I hope that all our audience who are seeing us our live on ICCM channel, so if they will be having any query related to these 3 topics, they can definitely ask these questions on their chat box. If possible, we'll able to answer them. So thank you all of us, and thank you so much, sir, all our expert panelists. Thank you.
Thank you, Neeraj.
हेलो हेलो चेक
अभी थोड़ा इधर खिसकाओ। हाँ या कुछ सेटलमेंट कर लेते हो
हेलो
फिर स्टार्ट कर सकते हो। हाँ 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 ओके अब बराबर है ना।
चेक
तीन मिनट के बाद रुकाना पड़ेगा दूसरे पर्सन आके बिठा के सेटल भी देते यानी जब तक सात का होता है उसके बाद shall we start sir shall we sir
yeah good morning everyone and uh, greetings from ISCCM to you all. It's a great honor and privilege to have with us today Dr. J.V. Peter sir, a senior critical care stalwart, professor of critical care medicine from CLC Vellore, and he's a who worked as a former director of CMC Vellore with vast experience in the critical care field. We will be discussing a very important topic in the modern healthcare today, that is green dialysis. Yes, it's an emerging concept in the world of healthcare that aims to reduce the environmental footprints of dialysis procedures while improving the patient care. Thank you so much, sir, for joining us. Dr. Peter, sir, it's great to have you today here.
Thank you so much for inviting me. I would like to thank the leadership at Criticare for giving me the opportunity to dialogue on this topic. I think it's an extremely important topic, and we as clinicians and doctors are generally not sensitized to a topic like this. So I
Yes,
think
sir.
it's wonderful they're doing this.
Superb, sir. Sir, green dialysis. It's really a new concept, no, sir. I was being astonished by hearing you this from you, sir. Can you just explain us the what is this concept of green dialysis and what are the main principles behind it?
Actually, green dialysis is a relatively new concept, as you said.
Okay, sir.
It's only about 12, 13 years old,
Okay.
where nephrologists started looking at this whole concept of how we can make dialysis more environment friendly. If you want a definition, it's a mode of dialysis which considers the environmental impact of dialysis and the measures that can be taken to reduce this impact.
Now, if you want a very simple catchphrase on how to explain green dialysis, one of my colleagues, Dr. Mithun Duncan, said, um, remove waste without producing waste. I thought it was a very simple catchphrase. We're trying to remove waste from a patient's body with kidney failure without producing waste. I think that sort of sums up what green dialysis is.
Superb, sir. So, yes, sir. The idea of reducing this both waste and energy used during the dialysis is fascinating, sir. So, sir, what environment impact will be there because of this routine dialysis, sir? What we are scared of?
I think that's a very good question because unless we know what is the magnitude of this impact, we can't address it.
Yes, sir.
So I look at it as four footprints
Okay.
that dialysis causes. We are all familiar with carbon footprint,
Yes.
but along with carbon footprint in dialysis, we also need to look at water footprint, energy footprint, and plastic footprint. If I may be permitted, I'll elaborate a little
Please,
bit
sir,
on
please.
this.
It's really needed. Sir.
Now, when we look at carbon footprint of a dialysis, we can a dialysis session is equal to taking 100-kilometer drive on a car.
Wow.
That's the amount of carbon footprint it produces. If you think that is shocking,
Yes, sir.
think about the amount of water that is required for dialysis. Now, a patient to undergo hemodialysis
Yes.
or peritoneal dialysis for 1 year, he consumes about 40,000 liters of water.
40,000, sir?
It is shocking. Now, you may ask me, why so much? After all, you're pumping some fluid and removing some fluid. To pump that fluid, the dialysis fluid needs to be extremely pure. So we use a process called reverse osmosis, which discards 70 to 80% of the water because of that purification process. Now, it's not only that water, but also you need water to make plastics. For to make 1 kg of plastics, you need about 18 liters of 180 liters of water. So it's highly water resource. So along with carbon footprint, there is water footprint, and the energy requirement also is equal to the energy that we consume as a household. It's not just the energy. 150% of the energy we use in a household, that's the amount you need for dialysis for a year. And the plastic footprint, you know how much plastic we produce with each dialysis? It's about 2.5 to 3 kilograms. It is 400 kilograms a year, which is equal to double the weight of a motorbike. So that's the amount of environmental impact that dialysis has.
So it's truly eye-opening, sir. It's amazing to know that that much of amount of energy has been consumed for each dialysis, sir.
Not just energy, but it's a whole impact on the environment. I'll tell you one more shocking fact. Now, a lot of greenhouse emission is happening with all the industrialization. Now, healthcare contributes to 5% of the greenhouse emissions, which is not terrible. It's reasonable. But dialysis alone accounts for 20% of the entire carbon emission of healthcare. So that is
20%, sir.
20%.
It's huge.
So it's a huge impact. So I think it's quite about time that we look at this more seriously as a healthcare professional.
Sir, what measures can we take to reduce the impact, this negative environment impact, sir?
Again, a lovely question. There are four components that I talked about: carbon footprint, we talked about water, we talked about electricity, and we talked about plastics. I think let's look at the common ones, the water.
Yes, sir.
Now, we need newer solutions to use less water. Okay, one is we can use slightly lower flow rates in the dialysis, and there are studies which have shown that by reducing the flow rate from 500 ml to 400 ml can save 24 liters. So just that one simple step without reducing the efficiency of the dialysis. So that's one thing we can do with regards to water management. Now, there are newer machines that they are trialing called sorbent dialysis, which can reduce your water requirement from about 120 liters to just 6 liters. So that technology is actually being tested out, and hopefully that will reduce the water footprint tremendously. Now, the industry also needs to come and help us because they need to come up with energy efficient solutions for dialysis. making energy efficient dialysis machines or RO machines that are energy efficient. So industry also has to support and partner. And as part of the larger green initiatives, our hospitals and ICUs and dialysis units should be green, eco-friendly.
Excellent. Thank you for your suggestions, sir. So with this, following these suggestions, we can reduce this negative impact.
So I've focused only
Yes.
on water, but
Yes,
there are
sir.
other ways.
Yes, sir. Yes, sir. Sir, we are hearing a lot of negative effect on the plastic also. So what as our country has done to reduce this plastic wastage, sir?
I think many of us don't know how much advanced India is
So
in
great, so
terms of
great. Really
management of
fortunate.
waste.
Yes, sir.
And I think we as a culture reuse,
Yes.
we repair,
Yes.
we recycle, which has sort of gone away in the Western culture where everything is use and throw culture. But we have been very, should I say, conscious by our culture to be, to give focus on the environment. For example, plastic. I saw a very fascinating study where they've said they use 4 metric tons of plastic and they convert it into what is called plasto concrete. That is pebbles, which later can use for concreting. So that's phenomenal. So you don't waste your plastic. It's a waste,
Yes.
but you don't waste. But cement industry also helps us out. 10% of the cement production thing can be mixed with plastic. And fascinating that our government uses plastic even for making roads.
Yes.
So I think India has led in this green revolution. It's not very well publicized. I think we should publicize it
Publicize this
well
thing,
to
yes,
the
sir.
Western nations that yes, we are green, we are conscious.
That's really insightful, sir. Sir, the other point, because the patient, when it comes to during dialysis, it is becoming too late, sir. Can we do before he reaches to dialysis stage, sir, in order to reduce this impact?
Very important question. And this is a question that you, as viewers, need to be conscious about. Because let's say you have diabetes, you have high blood pressure, you have cholesterol, you don't take care of it, over time you'll develop end stage kidney disease. So if you look after yourself, you also have a responsibility to the environment. You have responsibility to make sure our environment is green for the future of your children and your children's children. So look after yourselves, manage your kidney problems well, look after your nutrition, exercise, diet. All these will slow down the progression of the kidney disease to needing renal failure. So a lot is left to the patients also, not just healthcare providers.
Yeah. As you said, the prevention appears to be truly it's the key point for us, it seems, sir.
Absolutely.
Sir, the other point, what I say is what I'm having, sir, in order to reduce this impact, as the patient presenting too late, we are having a lot of negative effect. Can we go early for the dialysis, for this transplantation, sir? Is it helpful?
It's a wonderful question because once a patient is free from dialysis and he gets a renal transplant, obviously he doesn't need to be dialyzed. So that seems to be a good solution. But in a country like India, we need sufficient donors.
Yes, sir.
The cost of transplant is high. The cost of medications is high. Maybe in Western countries, because a lot of the transplant programs are supported by the government, it may be a good solution. But this is something that we can seriously think about also.
Yes, sir. That's a great point, sir. Sir, what are all the challenges faced by the healthcare system, healthcare institute in implementing this green dialysis?
I think it has to come from top down. If the administration of a hospital
Yeah.
is not interested, nothing is going to happen.
Yes.
So if the administration of a hospital says, yes, we are committed to greening,
Yes, sir.
we are committed to using resources that will make our environment better, it will happen. But I think the biggest impairment may be the initial cost.
Yes.
So you may need to, create a sewage treatment plant or a waste disposal, yard where you segregate contaminated and non-contaminated waste, or you set up a reusable energy like solar. All these are cost intense. So if it needs a mindset change and some funding to make it happen.
Yes, sir. As you said, truly, there is a lot of financial and logistic issue in order to implement, sir. Thank you so for clearing that. Sir, what advice you will give for an youngsters, critical care students who are interested to advance this field of green dialysis to implement?
I think we have a responsibility to them
Yes.
to impart this knowledge, and they also have to feel engaged,
Yes.
that it is for their own world in which they
Yes.
live,
Yes.
that we are making these changes. Now somebody may be skeptical and say, I mean, I'm going to give only a small contribution to this. But remember, the droplets make the ocean.
Yes.
If each of us can contribute to that one drop of water, our oceans will be full. So I think that's what I would advise the
Yes,
future
sir.
generation.
It's like invaluable advice, sir. Thank you, sir. And just to conclude, can we implement this green dialysis, sir?
Absolutely. I'm very confident we can. At our own institution at Christian Medical College, Vellore, we have zero water discharge from the campus to the rivers. We handle everything. And we use recycled water. We use it for our laundry, for our CSSD, for our HVAC system, for our lawns. Similarly, we have a effluent treatment plant to a sewage treatment plant. We have solar power. So it is possible. It is definitely possible and doable.
Yeah, yeah. Thank you so much, sir, for your time today and for sharing your expertise on this incredible important topic. Because as sir has already expressed all the important concept, how to prevent this environment impact and how to improve the patient outcome as well as society. And for us as an audience, we should take care of health properly and we should have a knowledge of this green dialysis to serve our society better. Once again, thank you, sir, for
Thank you
your
so much.
excellent,
Thank you.
insightful. Thank you very much.
Did we stick to time?
Yes, sir. बढ़िया सर. Excellent. One is to one. बहुत अच्छा क्योंकि सर सर नाउ प्रेजेंट I have sent you on your phone. अच्छा अच्छा सर ये द चेयरमैन and managing trustee W4C Critical Care Foundation. Managing trust. Yes sir. Trustee. Trustee W4C. W4C Critical Care Foundation. Critical Care Foundation. Correct affiliation. Sir, थोड़ा पानी दे दो सर. Please, some water for. घर बुला के पानी पिलाते हो. Okay, sir.
Yeah. Good day, everyone, and we'll welcome to this insightful session. Greetings from ISCCM. It's an absolute honor to be speaking with one of the stalwarts in the field of critical care, none other than that Dr. Narendra Rungta. Sir has played an instrumental role in shaping the field of critical care in India and has contributed immensely to the development of intensivist training and infrastructure. Today, we are driving into the evolution of critical care in India, the challenges we face, the way forward. Sir, now presently, he is a past president of ISCCM, founder of the Association of SAR Critical Care Society, is the international consultant for the FCCS from India. He's a teacher, he's a guide, he's an examiner for both adult and pediatric critical care. And now, Sir is chairing as chairman and managing trustee for 4C Critical Care Foundation. Sir, it's really a privilege to have you here, sir. So,
It's my pleasure.
so kind of you, sir.
It's my pleasure.
Sir, just we'll go ahead with the discussion about this evolution of this critical
Sure.
care journey, sir. So, sir, you have been the front foot of critical care in India for decades. Can you take us back to the early days? What were the biggest challenges you faced in establishing the critical care as a specialty in our India?
To be honest, Arif, I grew in an era where endotracheal tubes and ambu bags were futuristic equipment.
Yes, sir.
Saving money was more important than saving lives.
Yes, sir.
Because the poverty was a major issue. And if we ever got any equipment like that, my bosses would be more happy to keep them in cupboards than to make them available. And if there was a VIP in the hospital needing ventilation, then the team from OT would come somehow or the other, intubate and train one of the relatives to operate upon the ambu bag. So this was an era then we were taught, in fact, formally taught the art of mouth-to-mouth ventilation.
Yes.
And I am myself, I have done almost more than 1,000 mouth-to-mouth resuscitation of newborns over 3 years. So that was an era, and the challenges you can now understand. What were the kind of challenges?
Yes, sir.
Yeah.
That's remarkable, sir, because the early days were very challenging, it seems. Thank you for sharing, sir. And over the years, we have seen the remarkable advances in the critical care in India. From your perspective, sir, what were the key turning points that helped the shape modern critical care in our country, sir?
Three-word answer.
Yeah. What are the?
Establishment of
Yes,
Indian Society of Critical Care Medicine.
yes, sir. Yes, sir. Key point. Yes, sir. Turning point. We are
This has to be the turning point and milestone, the biggest milestone
yes,
possible anywhere in the world.
yes, sir.
That-
Excellent, sir.
Yeah.
Yeah, that is really has a lot of impact in the development of critical care field in our India, sir. You have been an instrumental in the growth of that ISCCM and critical care education, sir. How do you think that ISCCM has impacted the training and standardization of critical care practice in India?
You see, if ISCCM would not have come into being, there would have been none or a very poor development of critical care medicine as we see it today. ISCCM leadership initially had huge vision, and they developed the society as a democratic, professional society truly. And youngsters, the society caught the eye of youngsters. And the training that was brought and thrown open to the young doctors, and ultimately, it delivered. It delivered, and the outcome was amazing. Doctors over the country saw huge change in mortality. A lot of people were saved, big people were saved. So, it made a huge impact on the medical field in the country.
Yes, sir. It's clear that ISCCM has had a central role and pivotal role in shaping the critical care in India.
course,
And
yes.
your leadership has a lot of
I
positive
am
impact in the
a
standardization.
late entrant,
Sir, sir.
little late entrant, but I must give lot of credit to my predecessors.
Yes, sir. So really, we are really fortunate to have this ISCCM stalwarts and founders in India, sir. Thank you once again, sir. Sir, another question. How does this Indian critical care system compared with the global one regarding this infrastructure, training, as well as accessibility for serving the critical care in India?
No, we are now, on an average, we are at almost at par with Western critical care systems. Where we lack are few areas, and most alarming one is nursing.
Sure.
We have left them behind. We have not been able to give them stature, which may be social, which may be professional, and which may be economic. We have not taken care of I wouldn't say we have not taken care, we have not been able to take adequate care of our paramedical colleagues in critical care systems. So there, and I'm unhappy to see non-allopathic graduates being enrolled as residents. We could have empowered our nurses and technicians to take that role than to take help of non-allopathic doctors.
It's excellent balanced perspective, sir, because anyhow we have been started IDCC and training and the workshop and all that, hopefully.
IDCCN was started when I was the president.
So nice, sir. Excellent.
And we were sure that we must take the nurses along.
Yes, sir.
And since then it has not gone anywhere.
Sir, even today. So most of our parts of Indian country is struggling with the resource limitation in order to serve in the critical care field. So what are some sustainable measures to overcome this?
You see, that's not only our country's problem in isolation. That problem is there around the world in the most developed countries. There will be pockets of resource limitation in every field, everywhere, in every country. However, the government and the overall society, they have to get together. People understand it by public-private partnership. It has to come in a very meaningful manner together to offer these services in such areas. And government has recently floated few schemes like Ayushman Bharat, etc. I think it's not far away that we will be able to make available all these services to most of the people in our country.
Yes, sir. It's really insightful, sir. So in order to bridge this gap regarding this public and private sector, what measures we can take, sir, in order to improve this critical care in our country?
Startups.
Yes.
Is the new slogan.
Yes, sir.
And I think medical startups, small medical center startups have to come in big way. And they have to be meaningfully supported by government, financial institutions, and even the society. And government has to act in a manner that CSR funds and ATG funds are easy to come to them.
Yes, sir. So anyhow, from our Indian Society of Critical Care Medicine, we have been started that 10 bed ICU in each this one. Some program is going to be initiated, it seems. No,
it will be welcome.
Welcome.
Yeah.
So nice, sir. So nice.
Yeah.
Sir. So thank you, sir. The other one, sir. Now our India healthcare system is been revolutionized by digital healthcare. So what is the role of this tele and digital system on this development of critical care in India?
You see, it's a milestone. The whole world is becoming digital. AI is will be there whether you like it or not.
Yes.
It will come in big way. And layman,
Please.
which includes politicians, engineers, financiers, nobody wants to depend on too much on professionals like doctors. So by inventing AI supported centers, hospitals, systems, they will probably it will dilute quite a significant dependence on medical professional training system, and lots of small problems will be resolved by AI and digitalization of medical and health. Therefore it has to come, and that should make doctor's job also very easy. We do too many equations, too many form filling. Probably the AI system would do it for us, and we will have the uh, results on our table very soon, very fast. And recommendations probably should also be included in that.
Yes, sir. So thank you, sir. It's really an exciting vision of the future.
Yeah.
Sir, as you're a senior stalwart in this field, what is your advice for the youngsters who have been entering into our field, critical care field, as a
Karma-
training as a young practitioners?
Karmanyavadhikarasте ma phaleshu kadachana.
Yes, sir.
Do your karma,
Yes.
do it hard way. Don't look at results.
Yes, yes.
Results will come. It's your results are corollary to how much hard and sincere work you put in. So most of the youngsters are focused these days. I have no doubt about their future, and they will do extremely well. Fall into the system, fall into the times. Never forget your parents, never
Yes.
forget your country, never forget
Yes.
your town. So that's my, and you should be very sincere to your profession. And your profession means patient. Be patient centric.
Yes, sir. Yes, sir. So it's really inspiring advice, sir. So before we conclude, one the lesson from this lot of lesson you have gone through in this journey. So one lesson and one key message to the youngsters, sir, before we conclude.
Medical profession, moves continuously. It marches to progress and new developments. We have to leave certain things behind. Stethoscope is behind us. Ultrasound has come.
Yes.
So get updated every day. Don't insist on what you have been practicing. Yes, that's an asset, but build upon it. Get updated. Be in touch with literature. Attend conferences. Attend workshops. And that's how you will become the best professionals. Keep yourself open to the new developments and technologies. The coming era is of new developments and technologies. So keep exposing yourself to these technologies. Be sincere, be patient centric. Again and again, I say that.
Yes, sir. It's really great and inspiring, sir. So it has been an absolute privilege speaking with you today, sir. And your vast experience and contribution to our critical care field in India have shaped the profession in profound ways. So we are grateful for your leadership and wisdom. We look forward to seeing these youngsters, making them the guidance and helping them in growth shaping. Thank you once again, sir, for
Thank
joining
you.
us. It's really will be blessed to have you, sir. Thank you very much.
I have enjoyed.
Stop हो गया? Okay. Next.
ठीक नहीं होगा तो बरोबर आहे
check Hill.
लोकांना बी लाईव्ह होऊन जाते हेलो चेक 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 वन
this topic because really we had no idea about that video reviving. So in the quality improvement, superb.
Yeah, there's a few people that in India that are doing something similar.
Yeah, okay, we
Yeah.
missed that.
Yeah.
We missed it. And from now, after hearing your lecture, we'll be hopefully start our like start చేద్దామా? One second, please. Yeah. I can say as Professor of Surgery, Neurosurgery, Clinical Associate, and Associate Medical Director, Commercial Secretary of Hospital of University of Pennsylvania. Can I say?
Yes,
Yeah,
of course.
super.
Thank you.
Yeah, can we start?
Yeah, good day, everyone. Thank you for joining us today for this insightful conversation. I'm really delighted to be interviewing Dr. Jose Pascual, a senior pioneer in the field of critical care, particularly focusing on quality improvement. Regarding coming to Dr. Jose Pascual, sir, he's a professor of surgery, neurosurgery, clinical associate, and SSU co-medical director. He's a patient safety officer working from Hospital of University of Pennsylvania. So, and Dr. Pascual, sir, has a leading voice in leveraging innovative methods. And today we are going to explore the important topic of video review for ICU quality improvement. So, which is this video review has emerged as a powerful tool in ICU setting, offering a new insight in the patient care, team communication, as well as educational enhancement. Dr. Pascual, sir, it's a privilege to have you here. Thank you for joining us. Thank you for giving us time.
Thank you very much for having me today.
Yeah, sir, could you briefly explain how this video review has been integrated into the ICU quality improvement?
Yes, it's a great question. We have been doing at the University of Pennsylvania this effort in the trauma bay for many years. And so we decided that in the same way that you can watch your performance when you resuscitate trauma patients, maybe you can watch that in the ICU and learn from that experience to see if you could do things better or if you can repeat things well.
It's really a great explanation, and thank you for your insights, sir. So, because it's like acting as a simulation, like simulation way of learning. So what role does this video revise plays in identifying the gaps in the clinical practice or protocols in ICU?
That's a good question. Usually when we have mortalities or morbidities, we review them in monthly meetings where somebody, usually a physician, will look into the chart and find out things we could have done better in a patient who had an ill outcome. In this case, we can actually watch a video of when Mr. or Mrs. Smith had a cardiac arrest in the middle of the night, and you can watch how you could have done things better, whether it was to administer medications earlier, intubate earlier, or do other events. So in the sense that you have a lot of granularity, and anyone can watch what was done in real time, rewind the video, play it slowly, play it fast, you can find out better with more granularity what you could do better.
That's make a lot of sense. Thank you for highlighting that. And how, another question, how does this video reviving helps in the patient communication and collaboration in ICUs?
So nurses tend to be
communication.
Yeah, nurses tend to be more collaborative than physicians, and that's more natural in their practice. Physicians tend to think that they can make decisions themselves. When you do these reviews, it comes out very obvious when a team leader, for example, wasn't communicating with his nurses or respiratory therapist or pharmacist or even between doctors. So I think you're right. I think reviewing these with your nurses present, not just among doctors, helps with the remembering that in the future, perhaps better communication is the main message of one of these video reviews.
Excellent. It's a great point, sir. They can learn as a team while reviewing this.
Exactly.
Videos.
Exactly.
So another one point, sir. Well, so regarding coming to this patient outcome, how this video reviving impact the patient outcome? Can you share us any examples, sir?
So that's a good question. And at the end of the day, this might all be very pretty and very exciting to see video, but if it doesn't make a difference on patient outcomes, it's all very useless, right? And just because it's nice, it's not a reason to do. So we have not studied outcomes. We have had satisfaction where the providers had increased their satisfaction at managing difficult cases and learning from the difficult cases. But I have to say that that's the holy grail, which is to find out if ultimately that will impact on outcomes. I'm not sure how we will do that. How will we know that by doing video review, patients are having less mortality or less morbidity? It'll be very hard.
It's very difficult to compare.
Yeah, exactly.
Really, it's a powerful thing. So what appears is video reviewing will help as a powerful tool for education. So how this will be helpful for the critical care postgraduates to improve their skills?
Yeah, I think I'm going to bring in here something that an Indian intensivist told me yesterday after the session. He said that his ICU was video recording events outside of the room with security cameras, and that they had discussed in his ICU are saying, no, there was things that we could have done better. We could have predicted this. So at the end, I think if you are more honest with your own care, you will and your partners are with the group's care, then ultimately the patient wins if we all agree that we make mistakes, some bigger than others, and if we don't change our behavior, then the patients will suffer, whether my ego or your ego is involved in it.
It's an excellent, insightful, and excellent suggestion, sir. So, sir, regarding this, coming to this privacy and confidentiality of the patients while reviewing this video, how it can be maintained?
Yeah, that's a very good question. Often in these video reviews, they're of acute situations. The patient is naked. They have exposed wounds, exposed everything. They lose all their dignity. Right? So you've got to be careful. This is not to just do broadly and have the whole world come and take a look at the video and learn from it, the medical students, everybody. You've got to protect the patient. And so we only will do these videos when it absolutely has a learning potential, and we will only show the videos behind closed doors to the team. As we mentioned, we can't take this video in our back pocket and bring it to the medical school to teach a class of 150 medical students. We will not allow that because of what you're saying, the privacy and the dignity of the patient.
It's really great to know that the patient's privacy has been kept on the top priority while making this video reviewing, sir. Thank you for that, sir. The other point to discuss, sir. So regarding when compared to these charts and all that, how this video reviewing complementary help to this traditional way of teaching?
Yeah, there's others that have studied this in Houston and somewhere else in Melbourne in Australia, and they found that it's not 2 to 1, it's almost 10 to 1 the information that you can all pull out of a video in a specific event compared to flipping through the chart and looking at things that could have been done better. The information is so much more intense. Plus, if we didn't see it the first time, we can rewind and watch it again among 1 person, 2 person, 10 persons. So I think the comparison for the future is going to be very useful. Because when we do traditional chart review, there's very little information in the chart. Yeah.
It's really a brilliant point, sir. Thank you for sharing. And another point, sir, because you, while doing this video reviewing and all that, you face some of the challenges and barriers. Can you share with us?
Yes. So in the U.S., which is very litigious, right? Anybody who in a situation of a poor outcome, cardiac arrest, death, they will want to immediately bring to a lawsuit the hospital, the providers, and so forth. So the very first day that we enacted the policy of video review in the ICU, the very first day, that night, one of our patients had a cardiac arrest, survived the arrest, but the following morning, their lawyers came by and requested the video. And, the intensive care attending was not me at the time. He said no, he would not release the video. And they fought and they lost. And because this is a quality improvement practice, the video is protected. from the lawyers to get it. At the end, it came out that there was no video, that we don't record every single case. And in this case, it hadn't been recorded, but it didn't matter whether it was recorded or not. The video was not open to the lawyer. Now, 2 years later, the hospital had a case that had litigious, and the hospital wanted to see the video to prove that their doctors had not done anything wrong. And we also did not give the video to the hospital lawyers. So it has to be very, very clear that it's only there for us to learn from the experience.
Excellent, sir. I can imagine how challenging those days were at that fascinating moment. Sir.
Yeah.
Thank you, sir. And the other thing, because now the era is of all artificial intelligence. Sir. How do you think, sir, this video reviewing, how can it impact this in ICU settings?
That's a really good question, right? In surgery video review, where you have a standard procedure like a cholecystectomy, the AI systems have been able to predict the next movement, right? And so if you're operating on the gallbladder, right in the liver, and you stray a little bit to the left and you're about to hit the hepatic artery, the AI system will start blinking red and say, you're going too far left, go right? So that's video review in surgical procedures has already integrated AI. I'm not sure how AI will affect communication, interpersonal, situational awareness, communication, leadership. I don't know.
Yes, sir. That's really exciting.
What do you think?
As you said, there are navigating machines also in the microscope in neurosurgery when they are just doing that neurosurgery tumors resection. Now there are some navigator microscope where they can precisely notify the nerves as well as the precise vessels.
That's incredible.
In order to prevent the damage.
Yeah.
So as you really said, thank you, sir. And finally, before we conclude, for our youngsters in the critical care field who might be introducing this video review into their own clinical practice, what steps would you recommend from your side to take them to do successfully implement this video review?
It's difficult. It's a difficult navigation with your hospital, with your doctors and nurses, but also with your patients and families. And at the end, if you can explain to all these different stakeholders that we are doing this not for the money or for benefits of the nurses or doctors, but we're doing this for ultimately learning so that the patients improve, usually everybody agrees. Even the people who are going to be scrutinized, the people in the videos, doctors, nurses, pharmacists, etc., they will agree and engage into the process if we can all understand we do that for patients.
Yeah, that's great advice for the newcomers. And really, then when we are talking about we're doing all these things regarding to save the life, not to do the mistakes from our side, because it will be having a huge impact on the patient outcome. It's really, outcome. So if we can have a video review, like a simulation wise, we can do less trauma, less damage to the patient because we cannot get the life back. So once again, sir, thank you, Pascal, sir. Thank you so much for your insightful answers today. You have provided us with a deeper knowledge, deeper understanding on this video review, and as well as the impact, how it is going to impact in the ICU and the patient outcome. Thank you once again, sir, for sharing your valuable time and giving us the practical experience.
Thank you, Dr. Pasha. Thank you. Thank you. All right.
Thank you once again.